housekeeping items before we start the meeting. I want to welcome you all. And we will also be posting the PowerPoint for this session at the top of the chat. And we are also recording this session. So viewing of this session right now is voicing your approval for the recording and acknowledgement that you know we are recording for this session. We will also be posting an evaluation about 5 minutes before the meeting ends. And we would also appreciate that you would all take part in evaluation of this session so that we can only improve in our efforts. So with all of that, I would like to welcome everybody to the first of our four. And my name is Stacy Coop, and I am a Quality Improvement Advisor for Superior Health Quality Alliance. And I am joined today by my fellow team member, Christine Lamb, and she is also a Quality Advisor with Superior Health. And then without further ado, I'd like to introduce our speaker for today. And I'd like to introduce Erin Foss. And Erin serves as program manager and subject expert in opioid stewardship and addiction medicine efforts for Stratus Health. Stratus Health is the quality improvement organization in Minnesota. Erin has 19 years of experience in a variety of healthcare settings. Her curiosity and constant yearning to learn brought her to addiction medicine, where she was a shareholder in the programming development of a nationally recognized addiction medicine program. Erin has provided education, support, and mentorship to community health care organizations and county jails across our nation. So her efforts to employ medication for opioid use programs within their facilities has been surmountable. In addition, Erin is co-facilitator of one of the largest addiction medication echoes in North America, with determination to reduce opioid-related mortality throughout stigma reduction and educational efforts. Please welcome Erin today. I'm excited for your presentation, Erin. So without further ado, and then we'll have about 8 to 10 minutes for questions at the end. Thank you.
Sounds good. Thank you so much, Stacy, for the warm welcome and making me sound a lot cooler than I actually am. I would also love to note that prior to working in addiction medicine, I was an OR nurse for several years and have worked in long-term care on and off throughout my career. So it's been a really nice opportunity to kind of bridge that gap of where you all are coming from and where the addiction world is currently at. So I'm thankful for all of you and everything that you do in your jobs, because it's not been easy in healthcare lately. Next slide, please. So I have no financial conflicts of interest. Next slide. And today during this presentation, we're going to discuss a lot about stigma and really how our culture approaches substance use disorders and opioid use disorders, and sort of puts addiction into this bucket that's different than other chronic illnesses. We're also going to talk about neurobiology, recognizing addiction as a chronic relapsing disease, opioid use disorder as a chronic relapsing disease, substance use disorders as a chronic relapsing disease. We're going to talk about how trauma during the childhood years can definitely impact likelihood for addiction. And we're really going to define, what does OUD mean? What does SUD mean? Because those are going to be acronyms that you're going to hear me talk about during this presentation. Next slide, please. So, Christine, I think you're in control of our polls. So poll number 1, do you currently feel that addiction is a chronic relapsing disease like diabetes or cancer? And don't feel pressured to answer a certain way, just be honest. Prior to working in addiction medicine, I really didn't know what I think about know what I thought about addiction as a chronic relapsing disease until I learned a little bit more about the neurobiology. So it looks like everyone said yes to that. And then it looks like you also launched the second poll, which is, has addiction impacted any of your friends, family members, or loved ones? And it looks like everybody answered yes to that as well. So it really goes to show that addiction is something that touches everybody in one way, shape, or form. So it's so important to meet our patients where they're at. And then we'll end the polls if that's okay. Thank you for doing that, Christine. That was seamless. Okay. So some definitions that you'll hear me use today is SUD, and that stands for substance use disorder. And you'll also hear me refer to opioid use disorder as OUD. And the main message that we want you to take home is that substance use disorder, opioid use disorder, alcohol use disorder, all of the use disorders are chronic relapsing diseases. And there are medications out there that can treat these chronic relapsing diseases. So it's so important as healthcare that we identify that we as a whole in our nation treat chronic relapsing diseases. So why should addiction be looked at any different? Next slide, please. So we know that there is a lot of stigma surrounding addiction in our culture, right? Stigma is huge, and it goes from the way we think and our own internal biases to how others think to maybe how we talk about addiction medicine. And I think in our culture, it's getting better as education is disseminated, but we still look at addiction as a moral failing or a choice. And really, that's what I like to talk about and hit home. So many of my patients during their first visit with me as their addiction medicine nurse would say, yeah, I really started my active cycle of addiction because of a bone break or getting my wisdom teeth pulled or getting in a car accident. So it really wasn't a choice of theirs or any fault of theirs because opioids were necessary at that point in time to treat their acute pain, and they were needed. But we know that opioids are high-risk substances that are highly addictive, so they can be dangerous. And that's why it's so important that we work with our patients to make sure that safe prescribing is happening and close monitoring is happening when we are prescribing these high-risk substances that are appropriate sometimes. So really, other things to think about are addiction is hereditary. That's another component of this illness. If parents both struggled with the disease of addiction, it's very likely that their child will at some point as well. Also, upbringing plays a huge role in this. Past trauma plays a huge role in this. Socioeconomic status plays a huge role in this. So it's very multifactorial. But as a society, we still kind of err on the side of addiction as a choice, and it's a moral failing. So it's so important that we educate our peers and our patients about why this just isn't the case. I have not had one patient that said, yeah, I woke up one morning and I just decided to abuse my pain medications, and here's where I'm at. It all happened because of a life event that started that cascade. And it's also so important when we discuss stigma to use person first or person centered language, right? So instead of saying, an addict, say a person in recovery, or instead of saying that urine was dirty, say that urine sample was as expected or it was appropriate. So you're not stigmatizing things that come along with the disease process of opioid use disorder or addiction. So that's so important. And also, you'll hear your patients, using that old stigmatizing language when they're discussing their healthcare too. And that's okay to just tell them, hey, it's going to take an army to reduce stigma in our culture. So try using these politically correct terms when you're talking about your own disease process, because this is a chronic disease that you have. You're not an addict. You're a person in recovery. Like really, really be the light and be the example for person-centered language so we can really, really work to break down the walls of stigma in our culture. Next slide. So opioid use disorder as a chronic disease process. I always start this off with kind of getting the audience to think about this. Think about that one thing that maybe isn't productive or positive for your own health that you just can't give up. What does that look like for you? Is it smoking? Is it maybe drinking a lot of pop or caffeine? Something like that. I guarantee everyone has something that they know they should probably give up, but they just haven't yet because they enjoy it, or maybe their bodies are dependent on that. And for me, I'm definitely dependent on caffeine and coffee. I will readily admit that. Um, for me also, I know that cheese isn't really the best thing for me. I'm a little fluffy. I've been struggling with my weight my entire life, but do I still keep going for the cheese? You bet I do. I just can't give it up. And I relapse or lapse on cheese frequently. But you just have to meet yourself where you're at, forgive yourself, forgive your patients for their relapses. I also liken this to a patient with diabetes. Was being diabetic that patient's choice? No, it probably wasn't. Much like addiction. Was that their choice? No, it probably wasn't. And does a diabetic patient or a patient with diabetes, even though they're insulin dependent and have a high A1C, do they reach for that chocolate cake sometimes? Yeah, maybe they do. They relapse as well, and that is okay because they are on a medication that treats their chronic relapsing disease. And you're going to see more and more patients being admitted into long-term care facilities that are going to be taking patient or medications to treat their opioid use disorder. And those are going to be things like methadone or Suboxone or Vivitrol. There's a few medications that treat opioid use disorder, but you're going to see those more and more often as we really are starting to embrace addiction as a chronic relapsing disease. So I think that really made my light bulb go on. Is it's really no different than any other chronic disease that we're treating in our nation. Hypertension, diabetes, it all kind of falls in line. There's medications that help our patients succeed, so they're super important. And I think, notably, it's important not to be fearful of these either because they're very safe and they're supported by data and people are successful on these medications, which is awesome. Next slide, please. So, clinical symptoms of opioid use disorder. I really like to paint this picture. As people start their opioids for maybe that bone break or their wisdom teeth being taken out or surgery, whatever that means, their brain is going to become accustomed to taking these medications. We have these things in our brain called mu receptors, and they are what uptakes an opioid substance, and they're like a little cup. And an opioid comes in that are full agonists, like, your Percocets or your Dilaudids, pain medications. They come in and they fill in that mu receptor in our brain. So our brain becomes very accustomed to being filled in. And it really, really works. It treats the pain at first. People feel great, and if it's working as it's intended to be. But after a while, they need that opioid substance filling in that mu receptor in order to feel normal as they build tolerance. And if they don't have their mu receptor filled in completely, they experience opioid withdrawal. So I think it's really important to recognize people that are spending a great deal of time thinking about their opioid substance or worried about their next dose or perhaps overusing their substances. Those could be things to make your antennas go up that maybe my patient's struggling with an opioid use disorder and we need to offer some help. So, and I've had patients explain to me that withdrawal from opioids, the cravings are just overcoming. It's like the worst flu you can imagine times a million. You're incontinent of diarrhea and urine, uncontrollably vomiting. Seizure potential is extremely high. Also, a lot of suicide risk associated with opioid withdrawal. So this is a life-threatening thing. So it just kind of goes back to, we have medications to treat this chronic relapsing disease. So let's do it because they're very effective in making sure all of these things don't happen and patients are getting the gold standard of care. Next slide, please. So I kind of explained the neurobiology of addiction, or mu receptors, or what uptakes the opioids. So like I said, after a while, your brain becomes accustomed and it builds tolerance. And just because you're building tolerance or you're on opioids for a longer term healthcare need doesn't necessarily mean that you're going to develop an opioid use disorder. But just know these are high risk medications that we are prescribing. So just handle them with care and keep a close eye on your patients. Next slide. We talked about this. Addiction really doesn't discriminate, and one person could take opioids long term and be just fine, and another person may develop opioid use disorder. Like I said, it just really, really hits home with taking the time with your patients, assess your patients, kind of watch those high risk habits that we discussed for opioid use disorder, and just really, really be empathetic to their needs and listening. Next slide. So, adverse childhood experiences, for me personally, this was the most interesting thing that can lead to an opioid use disorder. And are any of you familiar with ACEs or the ACE assessment? I wasn't either. So, adverse childhood experiences assessment goes from a scale of 1 to 10. 1 being maybe, you had a super supportive family, there wasn't any substance use in the home, everything was normal or as it should be. Everything was great. 10 might be that you experienced physical abuse, sexual abuse, there was substance use in the home. Maybe you had a parent that was incarcerated. Lots of not so great things are happening in the home. Well, studies have shown that if you have an ACE score of a 4 or above, your likelihood of a substance use disorder is 86% higher than if it was lower than a 4. So I would encourage all of you to take the ACEs assessment. It's really interesting. So we talked about how opioid use disorder can be heritable and passed down from our parents or family members. We talked about being in an environment where substance use was a more normalized practice. Those can all be things that may lead into your patient having opioid use disorder later on in life. So just pay attention to those things. And I think it's just very notable that trauma really does affect the brain development. So I found that extremely interesting and just made me extremely empathetic to my patients and meeting them where they're at, because maybe they were never raised in a household where they had parents showing them how to go to work or not use substances or how to parent their own children. Next slide. So we talked about this. The younger that you're introduced to an opioid substance as well, the more likely that you may encounter addiction issues later on in life. But adverse childhood experiences are strongly linked to the cascade of addiction, but also to other chronic disease processes like diabetes, cancer, hypertension, all of those types of things. So it's extremely interesting how trauma and mental health can tie directly into many of the chronic relapsing diseases that we're seeing currently in our nation. And just think about it. Something that I ask folks a lot is if you would have someone admitted to your long-term care facility that was maybe getting metformin to treat their diabetes, would we ever question that treatment or shame that treatment or stigmatize that treatment? Maybe we would. I hope not, but probably not as frequently as you would see, oh, this patient's taking methadone. I just don't know about that. Or what does this look like for our facility? And do they need to go to appointments every day to get this treatment? There's a lot of stigma surrounding medications that treat opioid use disorders. But just think, we would never withhold or stigmatize a hypertensive pill or a diabetic medication. So why do we really encounter that in our culture with medications to treat opioid use disorder? Just something to think about. I've thought about that a lot. Next slide. So I think meeting people where they are is the biggest message. Listen to maybe what happened with their childhood. Usually there's a story that comes along with this. Like I said, I've never had a patient that said, yeah, I just woke up this morning and decided to start taking, 10 Percocets a day, and here I am. That's usually not how it works. There's a sequence to how tolerance, dependence, and maybe an opioid use disorder develop over time. And it's so important to use person first language. Remember, we teach in other areas of healthcare when we're talking about chronic diseases that we have patients with diabetes or patients with hypertension. So this is no different. We have patients with an opioid use disorder or patients taking a medication to treat their opioid use disorder. And when we're talking about maybe a urine drug screen or a drug test, even correct your patients, talk to them, break down that stigma. We don't say clean and dirty anymore. We say appropriate or inappropriate. Really, really help them to shape their mindset as well, because education is really how we break down stigma in our culture. Next slide. And I think it's so important, instead of addressing addiction by saying, well, why did you do that? Why did you relapse again? You're going to get so much further with your patients if you're just very non-stigmatizing, non-punitive, and you say, how can I help you? Tell me what happened. Talk to me about this. How can I help? So my favorite quote, as I have worked in addiction medicine, is by Maya Angelou, and it's do the best you can until you know better. And then when you know better, do better. That really hit home for me. Because as healthcare professionals and working in addiction medicine, I just realized we don't know everything. They don't teach us everything in nursing school. So we really need to take it upon ourselves to learn and how we experience the world. So, I got very little education on addiction in college. So I just wanted to share with you some of the main talking points and foundational components for how to start thinking about opioid use disorder as a chronic relapsing disease. I wish someone would have explained to me, why can't you just stop using that opioid? Why do you need to take a medication to treat your opioid use disorder? Well, it's not that easy. And I think that's so important to know and explain to people. Next slide. So everybody answered yes to addiction being a chronic relapsing disease at the beginning of this. So you just stole my thunder completely, because you're going to answer yes again. So I don't know if we need to launch this poll, but I think that that's wonderful that you all have opened your mind to the thought of addiction being a chronic relapsing disease, opioid use disorder being a chronic relapsing disease, because that means that you are being non-judgmental and non-punitive and non-stigmatizing when you're treating your patients, which is awesome. So next slide. So the next session, Dr. Bobby Redwood is going to be presenting about medication and behavioral health treatment opportunities with opioid use disorder. And I've heard wonderful things about him as a speaker. So please log in. You'll see the QR code to register. Help you all. I am very technologically challenged, so I can never get these to work, but Superior Health has a wonderful team. Just send them an email if you have any questions or thoughts about registration. Next slide. My contact information is below. If you have any questions or thoughts at all following this conversation, please feel free to send me an email. I love to discuss opioid use disorder and addiction medicine and everything that comes along with it. No question is a stupid question. Like I said, I started out exactly where you are, not working in addiction medicine as a specialty, and I had questions. And I've had to check a lot of my own stigma and bias at the door as long as I've learned more about addiction medicine. So nothing's a stupid question. I've probably heard it all. Reach out if you have any thoughts. Next slide. And then Superior Health has some great resources, QR codes again, that can link you right up with those. So check them out. Next slide. References. Next slide.
And then we're going to open it up to questions in the few minutes. We have about 6 minutes left. Erin, I was in our talking, you had talked about a football stadium. Do you want to?
Yes.
Yes. Do you want to go over that with the group? I thought that was quite interesting.
Yeah, so generally when I start presentations, I will just start them with a slide showing this group or whatever group I'm speaking to, their local sports stadium. So I'm from Minnesota, if you couldn't tell by my accent. So our Viking stadium, I think, holds about 66,000 people, and I think we're up to 118 opioid related overdose deaths this year. So more people than our Viking stadium can hold have died from an opioid overdose. So imagine all of those people walking into that stadium and they're all dead. Like that is what we are dealing with as a society. And it is an epidemic. That's why we're putting so many efforts into educating people about why medications to treat opioid use disorder are so needed, and all of these deaths could be prevented.
Are there any other questions in the chat? Otherwise, Aaron, what is your advice to give people? How do you explain to people when they are firm in their stance that opioid or substance use disorders are a choice versus a chronic disease?
Sure. I have seen a lot in my last 7 years of working in addiction medicine, and, sometimes it can be a choice, just like the development of other chronic diseases can be a choice. Hypertension could be linked to eating not the most healthy diet, and you develop high blood pressure. So I'll kind of liken it to other chronic diseases that we discussed. But then I'll say, I've taken care of an 11-year-old girl who was being sexually exploited by her parents and being shot up with fentanyl by her parents to keep her actively engaged in the cycle of addiction so that she could more easily be exploited. That you just have to meet people where they're at. We all have a different story and a different way that maybe we developed an opioid use disorder. But I think the biggest thing is to not be judgmental and just check your own biases at the door. Like I said, I wasn't perfect when I started in this specialty. I kind of wondered, why can't you just stop using that? You've lost your house, your kids, your job, your everything. Why? But once I understood that it is so anxiety producing, the thought of experiencing withdrawal, then I understood this is like the sickest that our patients will ever be when they're experiencing opioid withdrawal, and they will do anything not to experience that. So I think that's why it's huge as a society that we are open to offering medications to treat opioid use disorder. So our patients don't have to experience that. And it's normalized, and they don't have to feel shameful about that either. And they'll talk to you.
Are there any other questions for Aaron? We have a couple minutes left. Others, you can type them into the chat if you don't feel comfortable asking. But you can either ask, but you take yourself off mute. Otherwise, type into the chat. Otherwise, the slide link is posted for everyone to view. And with that link, Erin also had put a link for the quiz for the ACEs that she talked about, the Adverse Childhood Events scale from 1 to 10, which I thought was quite interesting. And we also have put in a link for a survey for this session. And then just want to, again, remind everyone of our next coming session, which will be on May 23rd. And we have Dr. Redwood actually talking about the pharmacology for opioid use disorder. And so that will be available. Please sign on. And we have 2 other sessions after that coming up. All right. With that, thank you, Erin. And again, please feel free to reach out thereafter if you guys have any further questions. Have a great afternoon.
Thank you so much.
Thanks.